Hi, I'm Dr. Arlen Myers. I'm President and CEO of the Society of Physician Entrepreneurs, and welcome to another session on SOPE School, Introduction to Healthcare Artificial Intelligence Entrepreneurship. Thanks for joining us. We are launching this course now. This is the third session. It takes place the second Tuesday of every month. And after this one, we'll have, I think, 4 or 5 additional sessions dealing sort of with the clinical dissemination, implementation, and various issues concerning its use. This is primarily designed for end user, physician, other healthcare professionals. We're not going to get into the technology and the data science. There are other platforms where that's more appropriate. So without further ado, this session is on healthcare AI rules, regs, and patient rights. And we're pleased and privileged to have Dr. Maruf Haider as our presenter. So thanks for doing this, Maruf.
Thanks, Arlen. Nice to see everyone. Good morning.
Yeah. So can you introduce yourself and tell people a little bit about how you got to where you are?
Yeah, so I'm an internist by training and an informaticist. I actually went to med school in Ireland. I followed my wife to become a doctor. I don't think she likes me saying that, but that's what I say. I did my residency in a chief resident year at University of Vermont, and really got into informatics then when I realized there was a niche for physicians who were interested in technology. Most of my career has been in Northern Virginia at a health system called Inova, where I was the chief health informatics officer after being there for a while. And now I'm currently with Carillion Clinic working on digital hybrid care models and dipping my toe into having an AI posture. I didn't want to say strategy for a health system yet, because I still feel like a lot of health systems are still kind of exploring what it's about. And it ties into this talk. A lot of people don't know how to think about AI, including regulators. So that's we can dive in when folks are ready. All righty. So really, also I just want to disclaim that I'm not a policy or legal expert. Again, as part of the roles that I mentioned, I've led organizational change in regards to, past acts and laws, and involved currently in AI, as I mentioned. And I have some disclosures in the reference section, like being a SOAP member, and things like that. So really, this morning, we're going to have a high-level overview on the regulatory landscape of AI. The coolest use of medical AI is when when AI does things that human providers, even excellent ones, can't. Like pushing the boundaries of performance, getting rid of meaningless tasks, predicting things that maybe a human couldn't. But for all that promise, there are headwinds that we must face. It's important to recognize those headwinds. Velocity, the rapid development of AI and integration of those developments by tech giants is an obvious one. Challenge two, what to regulate. What misinformation is out there? What acts of badness do we regulate? As an example, a baseline for safe AI practice has been laid out in a framework for AI risk management by the National Institute of Standards and Technology to increase trustworthiness of AI. And there has been an executive order, which we'll talk about soon in the next couple of slides, that really kind of double downs on that concept. Third challenge is who regulates AI and how? Do companies do it? Does the Fed do it? Would you regulate AI by licensing the teams of people who make AI, kind of like a professional, medical certification or things like that? How do we approach regulation? So I'm going to ask a question to the group. Are current regulations enough for AI? What do people think?
So Lawrence, do you want to answer that?
Sure. No.
No, give me a why. Why?
Yeah, so why?
Okay. Well, AI
That was an
in
easy one.
okay, I'll qualify it. AI is very new. It's almost like any new innovation of a car, and you need to road test it, road test it, road test it. Then it has to go through the uh, crash test safety regulations before it, and other regulations, fire safety, etc., before it gets out into the showrooms and to be sold. AI hasn't had it.
Yeah, and actually a good example of that are electric cars. Uh, in fact, a recent fleet of General Motors electric cars were pulled off the market. I mean, these are self-driving cars, and so that's the interface of the application of artificial intelligence, in this case, to automobiles. So they got pulled off the market because of a self-driving accident, and we've all heard about Tesla self-driving accidents, and pretty much every car maker that's trying to do this has had some issue. The second point is that there was a recent article that they had to rescue a hiker off of a wilderness area because the Google map he used was wrong. And he wound up in the middle of nowhere. And fortunately, he had a satellite, SOS button so that they could understand where he was. But in fact, when they went back and looked at it, the Google map was wrong. Another example is, the Malaysian Airlines crashes where the pilots didn't override the autopilot and wound up with a bunch of passengers at the bottom of the ocean. And the final point is that the recent surveys indicate that patients, doctors, and health executives simply don't trust AI. And what's interesting is that women seem to trust it even less than men. Now, I don't know why that is. And if we have women in the audience, they can chime in, but you could have your own theory. But the point is, there's so much doubt and mistrust that people think we need to get our arms around this thing. And the final point is that patients, doctors, health professionals don't think that industry or the government can be trusted to regulate it. So I don't know who else is out there to do this, but it sounds like we have an awful lot of work to do.
Yeah, I think what you guys are describing or what you described is that there are many times technology like AI gets out ahead of guardrails that legislatures and regulations eventually put on it. But what do you do in that gray space, right? And that eventual guardrail might be too narrow, as you kind of insinuated. And another question, just last question of this is, what do you consider AI? Is it a software? Is it a device? Like I said, do we consider it just a product of a group of experts who we have to certify? What would you guys consider AI?
Harvey, what do you think?
That's a good question as far as should we certify people with AI. It's a wild, wild west, and you see all these people on their LinkedIn call themselves AI experts, and some of them really don't know anything about AI, but they're just using it for marketing. With that said, I guess with your credentials and what you know and what you say, it's to me your certification, especially when you're dealing with other healthcare providers. We can smell people really quickly when they're BSing us or not. But I think at the hospital level it gets a little tough because there is not that other counterpart. As physicians, if we're going to use AI, we're really strict on we like it, even if it's the Mercedes. We may be on a doctor's side saying no, this ain't going to work, and so we on ourselves will police ourselves. But the hospital administrators that are out there that may not know anything about AI, that gets a good sales pitch, they may force this AI on us. And so it'll be interesting which way this goes. But big picture for me, On the regulation side, I literally was in a talk this morning in Germany, and one of the things they said is it was kind of funny. They said the U.S. innovates and Europe regulates, and I thought, that's actually pretty true.
That's a good point,
That's
Harvey. Yeah,
that's
that's
pretty
a
clever. This, Benny, maybe you can chime in on this. This point of who is the expert is particularly relevant in who gets sued. Because one of the issues that we are dealing with is when artificial intelligence takes you down a trail that is not on the Google map, who gets sued? And we don't know. I mean, lawyers and people are trying to figure that out because it has to do with medical malpractice and all that. But ultimately, it's going to come down to the defense and prosecution witness lawyers putting up experts. So the doctors are going to get sued. But if you're being called as an expert witness, the first question that the attorney is going to ask you on the stand is, doctor, he has to qualify the expert, or she has to qualify the expert. So they're going to ask you, Arlen, who are you? What do you do? Tell me your story. And oh, by the way, you're being called as an expert on artificial intelligence. What credentials do you have? What have you done? How do we know that you're in fact an expert instead of somebody that's just wanting to get a lot of money to testify for the prosecution or the defense? So we don't really, it's an important question and one that we're going to have to answer. I don't know the answer. The other problem is we've done some work with clinical informaticists and fellows in the clinical informatics training programs. My view is, and what I'm told is, that actually artificial intelligence education and training is not that present in a clinical informatics fellowship. Is that true, Maruf? Was that your experience?
I think, my training was many years ago, but I would say it's not. I think it's still, I would probably say an informaticist would consider AI, like how do you incorporate AI into workflow and things like that. That sort of deep dive into data science or kind of explainability of AI models is probably not where it should be in the informatics world, I would say. And Arlen, a comment to your point about the doctor being up there. I think those comments also relate to informed consent and explainability of an AI model, and then the patient's right to know how that AI model works. I mean, all of that ties into this, and that's what the regulatory landscape has to figure out in conjunction with us, and we really have to be a voice to that.
Yeah, Benny, have you had any experience as a so-called expert? Not that you're not, but as an expert, either.
You got to write the first description.
Yeah, right. Like fake it till you make it. In product liability or in medical malpractice?
Yeah, I think so. So there's been about 110 legal cases in the US, and most of them have been either civil or IP or contract law cases. So to your point, Dr. Myers, a lot of it has to do with how do we define AI? And given the number of prediction models and various applications, it's going to be difficult for any regulatory agency to govern them all. And so to your point, I think that AI experts need to stay very close to the problem that they're trying to solve and the application for which they're trying to use it. And I think in general, when it comes to liability for the physician, Dr. Ehrenfeld, the president of the AMA, really advocates for this a lot, especially given the fact that regulations puts the ownership of privacy protection on the physician. So if you're not learning about AI and if you're not taking courses like this, Dr. Hayter's course, then you're putting yourself behind the 8 ball in trying to understand how you can protect yourself in your practice.
And that gets to the issue of how and when is AI the standard of care? Because that's basically the benchmark. So in a malpractice suit, the question really is duty, breach, causation, damages. Is there a duty to the patient? Did you breach that duty? And essentially that means, did you violate the standard of care? Did that cause, is there a proximate cause of what went wrong to your use of that technology, which is the standard of care? And did it result in damages? Did you hurt the patient? Or somebody hurt the patient? So the standard is, how do you define the standard of care? And that happens, I mean, there is no frank definition of it. It's really, what would a reasonable physician in that circumstance do? Literature, white papers, et cetera, all this experience, all the stuff that we do. That's how we wind up doing what we're doing. That's the guardrails, like that's the standard of care. But we haven't defined that yet. So we don't know that yet. So I think it's going to take a while to get all this sorted out.
I'm going to use your standard of care as a transition to this slide. How do people feel about this opinion? I'm going to be very, this was an opinion during the Industrial Revolution, right? That's when things changed. People said children shouldn't work at young ages in factories. And the Industrial Revolution pushed that forward. Like the Industrial Revolution, you know, when regulators and folks are talking about responsible AI, they're really talking about this industrial revolution of digital change, right? How do we think differently? Back in the day, the concept of a child not working till a certain age, till they became an adult, was a different concept. And we're going to have to entertain different concepts in our world, in our realm, during this time. So, State of the Union of the United States. You know, Harvey mentioned that the Germans said we regulate. You know, I think, Harvey, that I was going to make maybe not such a poignant, but a similar comment. The EU is very holistic. They have a kind of an AI supervisory authority, plus they rely on their existing sector regulating bodies. United Kingdom has no centralized AI regulation or AI specific regulator. They just rely on the existing sector regulatory body to set guidelines and principles based on that sector. The United States, you know, I think is mixed, and I think that does promote more of a innovative culture where they have some general guidelines, some voluntary commitments from leading AI companies, and also an ask for sector-specific strategies. There's some shadows to that, in the sense of when you have so many players in the pot, you can get very confused very easily, even within departments. And the most sort of hot off the presses thing about US AI governance is that President Biden signed an executive order to direct the federal agencies to regulate AI as it's developed and deployed, with a 6 to 12 month timeline to these agencies. So how do we approach, or how do we look at that executive order, and what's its approach to healthcare? The HHS, the Department of Health and Human Services, is going to develop a task force within 1 year to develop a strategic plan on how to responsibly use AI. Again, responsible use of AI is the buzzword, I think, in sort of the current regulatory timeframe. It's focused on civil rights and privacy, much like that concept of the Industrial Revolution and that example of child labor. This is sort of the new protection that we want to do, protect people that aren't represented, patients' privacy rights. You can see here that HHS has a commitment to have some regulatory agility because of the velocity of how AI is being developed, improve a safety program related to that as well. The order describes innovation, and that's really expanding grants for research. I thought it was interesting that specifically personalized immune response profiles was put in there. Maybe that's a COVID response. But workplace efficiency and sprints, kind of AI tech sprints to support small business and veteran development, it was focused. And there's a payer focus, which is interesting. Benefits on how you administer claims, the quality of care, particularly in ACOs, and a patient experience was mentioned. And I thought a particularly interesting comment was appropriate human oversight of the application of AI generated output was interesting. Because Harvey, I bet I've heard you speak in other venues, and you've talked about being in a car, going to the ER, and all these things are happening as you're getting ready to go to the ER, right? And there's a lot of autonomous decisions happening there in your story, which I think is pretty cool. But in current regulatory speak, there's fear for that, where they say a human has to have oversight on this for it to be regulated. And just these are the data privacy, disclosure, bias, anti-bias, safety. These are all kind of general obligations that executive order puts across all sectors, including healthcare. All right, so more conversation for us here. The question here is really about this fake application called Heart Assist. So the question to you guys is, should it be considered a device? I'm going to read the paragraph and then we can talk about it. Heart Assist is an innovative clinical decision support software. It was developed to help cardiologists in particular in managing heart failure patients. The software has a complex algorithm that analyzes patient data from their health records, lab results, and health monitoring data. Based on that analysis, it creates personalized treatment recommendations. It does that by being integrated with a lot of data sources, as mentioned. It provides specific medication doses and lifestyle changes suggestions. And it calculates the risk of future cardiac events based on that data. And it continuously updates how it recommends things based on the new medical research and patient outcomes, which are part of its data sources. How do we regulate this? Do we consider this a medical device? Do we just say, hey, it's a lifestyle application, let's just put it on the App Store? I see Lawrence has his hand raised. Let's go from there.
Okay, so this is diagnostic. Does this have FDA approval?
That's the question. Should it go through the FDA? Should we regulate this as a device, a health device?
If it is diagnostic, as per the way it's been described, what I'm reading here, the answer is yes. Otherwise, the FDA would deem it illegal. And
I think there are a couple of sub questions. Number one, what is the FDA definition of a medical device? And that gets to Lawrence's point. And it's very specific. And most of you, I think, have seen it. And if you haven't, you go to fda.gov and it'll give you the definition. That definition, I think, conforms to what this is. Yes, it's a medical device. So simplistically, it diagnoses, treats, etc., some condition. The second question is, should this particular product be approved by the FDA? Thanks for putting that up, Harvey. And that's a whole nother issue, because, for example, on the bottom, the learning component, you make a drug and it gets approved by the FDA and the drug stays the same for 20 years. But every time you create an algorithm, it changes essentially every minute based on new information. So it's a continuous thing that evolves. And so where in that spectrum of evolution, or is it we just approve the whole thing and as it evolves, and you're good to go? And I think and in many instances, they're trying, I mean, you know, there's several hundred now clinical decision support approved FDA products. So this is not the first time we've been to this rodeo, and they're still trying to figure it out, but essentially they're getting, you know, trying to be more circumspect about how they're doing this. So the answer, in my view, the answer is yes. Now, I'm not a reg affairs expert, but that's, yeah. And I think if you're an entrepreneur and you're creating one of these things, you need to be positively, absolutely sure that you get the right answer from the FDA before you go down this road, let alone who's going to pay for it and how they're going to pay for it. But that's a whole nother story. Yeah.
Hit the points I wanted to make. I made it, I tried to make it a little vague for the purposes of discussion. You know, an argument for regulation is exactly what Lauren said, that diagnostic wording. It's algorithmic recommendations might be seen as substituting professional judgment than just informing it. And that's a reason to evaluate it, regulate it. Maybe an argument not to regulate it is that it supports rather than replaces professional judgment, which is like the opposite of what I just said. So I think this is to just illustrate what a regulator or what a entrepreneur might actually say to themselves. How do I know? The FDA actually, I think, is a really good leading department on how it approaches these things, and has a lot of good tools. They have a site where you can go through a series of questions to see if your product actually is considered a medical device. And, you know, I think for safety regulations and clinical autonomy, you might be able to argue that you could regulate this. And by clinical autonomy, I mean, you know, if Heart Assist AI just makes a recommendation and the clinician just kind of says, yep, let's do it, without really having a decision-making thread in there, that could potentially lead to harm, particularly if Heart Assist makes a mistake.
So I have another question, and that is, this is a home blood pressure monitoring device that I use. So my question is, should consumer electronic devices that you see at the Digital Consumer Electronics Show in Las Vegas be required to be FDA approved? Because essentially, I mean, what's the difference if the point is to get people like me and other people to use blood pressure cuffs at home? Why would I want to use one? And we all know that there's a million of them, and some of them are valid and some of them aren't. So why wouldn't we require them to be FDA approved if you want to sell it to any or manufacturer or all the regulations for? Because everybody, including an Apple Watch and all the remote sensing devices. And now, Lawrence, you may speak to this, but as you well know, Apple may have to pull their Apple Watch off the market because of an IP infringement. That's another story.
Again.
But the point is, what's the difference?
Well, I think that IP aside, on a consumer level, something that you can buy in a Walgreens, CVS on the blood pressure readings, effectively, their home use, they're not going to be diagnostic. They're more of, okay, my blood pressure is 210 over 150. I need to see a medical professional sooner rather than later. And then you go into a medical professional environment and they do all the checks, and they use devices which they can make strong decisions on. And depending on what they use, generally speaking, they're FDA approved. So a home health scenario and the Apple Watch scenario, a lot of the wearables actually have FDA approval if they're going to be diagnostic.
Yeah, but I don't want to belabor the issue, but in terms of hypertension or high blood pressure, when you go to a doctor, they're going to do the same thing you did at home. They're just going to use a different device. I mean, that's how you make the diagnosis. So that's my point. And I don't know what the answer is, but I think we're gradually evolving into more. And this gets into the federal bureaucracy because now you're dealing just not with the FDA, you're dealing with the FTC, you're dealing with the Consumer Products Protection Bureau, you're dealing with, in some instances, the SEC. There's a whole bureaucracy that wraps their head around this. How do you protect the consumer? What's an unpaid trade practice? What are you telling people it does that it actually doesn't do? That all that kind of stuff. So it gets pretty complicated.
Yeah, I think, and that was really the point of that case study is it's complicated and our ideas will change over time. But there is an element of, what should be regulated and what should be commercialized, unregulated commercialized. We briefly touched this anyway, so I'm not going to go through it, but I think AI systems that will perform or assist with clinical tasks related to, and as Lawrence has continued to mention, diagnosis, interpretation, or treatment. I think that's the key phrasing when you're asking yourself, is my algorithm a medical device? That's I think the crux of what the FDA will look at. Other AI systems that are classified otherwise, they are services or products, don't fit that criteria. And just to say, more about the FDA is that there is a rise in all these algorithms because and there is a rise in certain tools using multiple algorithms, right? I use algorithm A for this, algorithm B for this, combine all my tasks together, and that's what my device does. So there are a lot of challenges that the FDA is trying to manage. And, I think they're doing a reasonable job there. I think they're the leading authority in a regulatory approach tailored to AI and ML technologies used in medical devices. And just, top three again of AI, ML algorithms being submitted are in radiology. Really 80% is radiology, maybe more, cardiology, neurology. And the top three companies are Siemens, Canon, and AI Doc. FDA side also has an Excel kind of database where they put all these, so you can even go look yourself.
Harvey, you put something in the chat about using a deep fake, and that brings up another issue. So are deep fakes, be they video, audio, imaging, avatars, you name it, is that a good thing or a bad thing in medicine? And we understand that most of us understand the downside: misinformation, cybercrime, fraud and abuse, phishing, et cetera, et cetera. But you've already given an example of using it to educate or inform. So give us your thoughts about, are deep fakes in medicine a good idea?
Yeah, big picture, I think it is. There's always two sides of technology, right? Just like a car, you can kill someone with the car or you can drive to work with the car. With AI, I see the same thing. Why not use the holes in healthcare? And for me, getting podcasts and healthcare information out quickly was important. So I created that deep fake and that's how I use it. I have control of it. With that said, I have so much video out there that anybody could clone my voice and pretend it's me. Now in medicine, there's different things that I'm working on developing for companies, but one that's going to be really cool will be simple video discharge instructions, where your doctor now, it's kind of deep faked, but then it's giving the discharge instructions or follow up with your doctor. At one point I owned 8 emergency rooms, and one of the biggest things is them coming back. And one of the things that I piloted at the time, we didn't have AI, was just a simple video follow-up, and I had every doctor do a quick little video, and then we'd send it to our patients. And granted, we only would get a handful of patients a day. That's the business model. But using now the power of AI, man, you could totally do this now. And I think these deep fakes would be amazing. Again, it's the hands of the user.
Yeah, you know, I think with that deep fake, it also raises the question of transparency, or, you know, hey, AI was used for this.
Yeah.
So I think I interrupted you.
No, I love that. You're right. The mayor of New York City, I forget how many languages he did. He did something like over 50 languages, and he sent out a email to everybody, and some people were pissed off. They're like, man, he's not being transparent. But I think at the end, lesson learned is be transparent with your constituents. But I thought that was a great idea because, again, had he not done that, a lot of people would have never heard his message. And so now they're literally hearing it in their native tongue, which is even better. Now, hopefully the translation was done correct. That's another story.
The other part of this is, I agree. I think that, you know, this is like the conversation when ChatGPT came out and New York City banned it in New York public schools. Well, that's kind of, I mean, really, it's there. The cat's out of the bag. You got to use it, figure out how to use it, do the right thing. I think it's the same thing with deepfake and all the other stuff, but there is the issue of the ethical and responsible. I think responsible use is one thing, ethical use is another, legal use is a third. So who's going to regulate that at the hospital system? So Harvey, if you're the ER contract doc at the University of whatever, or some integrated delivery network, and you start pumping out this stuff, you're going to get somebody's attention. And the question in administration, and I think healthcare executives are trying to figure this out. So how do we monitor it? Just like an ethics committee where we're dealing with ICU end of life issues. How do we do this? And I don't know the answer to that, but I think what's going to happen is that, and I've suggested that hospital ethics committees are going to have subcommittees of AI ethics subcommittees that are staffed by people that understand artificial intelligence, data scientists, informaticists, lawyers, public advocates, policy people, ethics people. Doctors just can't sit around a table and say yes or no. That's not going to work.
Yeah, I think, you know, that the health system that I'm at, that's really discussions that we're having. We're trying and bringing all those groups to the table because you really need that holistic approach. Arlen, is this a 40? We have 45 minutes or even an hour?
We have an hour.
Okay. I have another case study that I'd love to talk through, but just the point of this slide is the FDA and HHS we've talked about a lot, but I wouldn't forget, and Arlen, tying to your comment of health systems and how they should regulate and make sure that they remain safe as an entity, you know, really applies to their local state laws and regulations. That those regulations will have a factor on how their approach to AI happens. And the FTC, most people don't typically think of the FTC, but they are a body that looks out for consumer protection and privacy. And when we talk about deep fakes and things like that, they can be an element as well that also goes after issues where they think it's.
I'll give you another example. So somebody who is a mid-level practitioner, a DNP, doctor of nurse practice, not an MD, not a DO, sends out a deepfake patient information video or discharge instructions and introduces it as, "Hi, this is Dr. So-and-so," using those words. So now you're getting into the issue at the state level of scope of practice creep and who can call themselves a doctor. That's an example of what you're talking about.
Yeah, it's a great example. All right. So another discussion topic. Company has created an AI system for diabetic retinopathy detection. It has high accuracy ratings. However, based on the data it has access to, it can train itself and improve its accuracy. We mentioned this earlier, that concept of adaptive AI. should this improved system be re-regulated, go through the process again? What do you guys think? I feel like Arlen or Lawrence had an opinion earlier in this talk about that, or mentioned it. What do you guys think?
Well, first of all, I don't think that the regulatory apparatus is equipped to keep up with all this stuff. I mean, there's just too much demand and too little supply in terms of manpower to regulate. So practically, I just don't think it's feasible moving forward. So given that, and a lot of this is not too unlike a 510(k) approval in a medical device with a predicate device. So I think what's going to evolve is a streamlined process for reapproving, updating, amending, supplementing some sort of application or document that says, here's what we did last time. Now, 6 months later, pick a number. Here's what we got now. It's pretty much the same as what we did 6 months ago, but we've added XYZ, we've incorporated the stuff, here's the changes we've made, and actually it's gotten better or worse. Because now we're hearing that as, there's drift. So the more you use the learning model, the less accurate it actually becomes because it deviates from the training data. So I don't know how we get around all this stuff, but I think the practical reality is we just don't have the horses to do this yet.
Yeah, Arlen, I think you're right. Before the FDA looked at devices the same way it looked at drugs, like static compounds, right? When the FDA approves a device, the manufacturer can sell it. It needs regulator sign off before upgrading to a new version. But AI is totally different, as you just described. And the FDA, I think, is working on what you described, a predetermined change control plan, if you will, where kind of real-time monitoring of adverse events kind of affects that recertification. It's just a way to do it. It's a cycle. And the FDA is also looking to evaluate the organization. I would almost call it the culture of that organization in certain ways. So if you pass that kind of good cultural recommendation assessment, these kinds of things become easier for you.
And I wouldn't be surprised if they don't use AI to monitor AI.
Yeah.
Because, these days we're monitoring everything and figure, what happened. So if you're the FDA and you have this AI tracking of AI, you're looking at all this data out in the universe and it should be able to tell you same, better, worse.
Yeah. Lawrence had his hand up. I'll just make one comment and then Lawrence go. When we talk, I mentioned real-time adverse event monitoring. That's, as these AI models improve or get worse, you need that real-time monitoring to make an assessment. And I think there's some groups that would say the FDA doesn't have that authority to do that. So there's some nuance there in terms of what the FDA wants to do and maybe can do. And I'll let Lawrence go.
So given the example that you've put up here, is this a software upgrade or is this a brand new device?
I think that's the question. You asked the question better than I did, but that's the difficulties we have in this topic.
Well, if it's a new device with new software, brand new software, then yes, it will need to be re-regulated. But if it's just an existing device with a software upgrade, then I'm not sure it needs new FDA approval.
Yeah, I think you could argue that it might be an upgrade, but there are probably some people who say, if the learning changes it immensely, is it new software? But
It depends on how it's presented, doesn't it, by the manufacturer or the
Yeah.
supplier.
We have 15 minutes, Maruf, if you want to pace your presentation.
All right, I got more. I mean, most of the rest of the discussion is prompted for discussion. So I feel like the concepts that I wanted to cover, we've kind of later on in this presentation we've kind of covered in discussion. So I'm okay just going through these if you are.
Okay, great. Yeah, it's up to you.
All right, so I'm going to just read you the prompts here. The question really is, again, to regulate or not regulate. And this is in the sphere of clinical decision support tools. You've created a product that analyzes a patient's family history, genetic profile, and prior test results to say, to push the direction of more colonoscopies to screen for colon cancer. Arlen's created a product that analyzes the patient's entire chart and recommends more frequent colonoscopies based on its own pattern recognition, which was done from analyzing large national data sets. Do we regulate both? Do we not regulate one? What do you guys think?
So I want to take this in a different direction. So I'll give you an example. I'll give you an actual case. My wife went for a, quote, screening colonoscopy. And there's a whole lot of issues with what's screening and all, et cetera, but let's just take it. It's a screening colonoscopy. That was appropriately recommended. Incidentally, a lot of colonoscopies are recommended for people over 75 and they shouldn't be done, but that's a whole nother story. So it's an appropriate recommendation for a screening colonoscopy. She has the screening colonoscopy. Fortunately, everything turned out fine. But I'm sitting in the post-acute, in the PACU, in the post-acute care unit, waiting for the doc to come out and tell me what happened. And, when you have a screening colonoscopy, they give you the pictures of your colon because they take pictures during the procedure. And fortunately, everything worked out fine. So you see these pictures of the inside of your colon. That's normal. But in the description of the report, which instantaneously is generated after the colonoscopy, it says artificial intelligence was used to screen for polyps. Now, my question is, should the patient know that? So now we're getting in. The title of this presentation is Regs, Rules, and Rights. To now, we've talked about regs. Rules, we've talked about. What guardrails should health professionals have to guide their use of artificial intelligence? So we've talked about ethics committees. Now we're going to talk about patient rights, patient bill of rights. What should the patient, and incidentally, do you get charged an additional fee for using artificial intelligence to monitor the video during the colonoscopy? So that's my question to the group, because I don't think that was included in the informed consent, which you brought up before, Marie. Like, you are consenting to use for the doctor or health professional to use artificial intelligence as part of this procedure and guide their treatment. So suppose the artificial intelligence said, there's something there, but you might not see it. So should the gastroenterologist take a biopsy of that place where otherwise they might not have done it because they didn't see it? So how do you feel about that?
Yeah, Arlen, I think you teed it up well. It's the informed consent is the topic here. I'll let Lawrence go.
So when you have an X-ray, the radiologist will look at this, and in their program to view and diagnose, if necessary, the X-ray that they're seeing, they use AI, and they have been for years. Do we have to sign consent for that as well?
Well, I think that first of all, when you go to get an X-ray or any procedure or any treatment, when you go to see a doctor for anything, they're going to shove a form in front of your face, or these days you're going to have to sign on to it on the patient portal ahead of the visit. That consents to pretty much anything anybody wants to do, as long as it's reasonable. So I think that's included as a sort of broad brush consent to treatment. Now, the same thing applies to consent to surgery. That's a separate procedure consent. And we can get into a whole long discussion about, does that make any sense at all? Because we all know nobody reads the consent. Nobody understands the consent. And when things go wrong, that is not a bulletproof defense by any means. But we're talking about a technology that is relatively new. And to the previous point, any innovation is a leading indicator. Any regulation and oversight is a lagging indicator. It's the very nature of innovation. So again, we're in the fifth industrial revolution. It was the same thing with water wheels and steam engines and electricity and all the other stuff, the computers. So that's the issue. Maria, is there an AI patient bill of rights or informed consent that should be signed by every patient?
So this is a lot bigger issue, and I think we have 2 or 3 issues combined in this one. I would start with you are absolutely correct when you say innovation is the leading edge, because I was going to use the diffusion of innovation theory. So whenever we have a new thing that's coming up, it takes time to get diffused into our everyday practices. I'm focusing on healthcare practices. So for example, when we are starting to teach the use of calculator, use of our keyboards and laptops and Google Scholars, now we have AI integrated in there. All of our Google searches or internet searches are based on that. So nobody at this time in academia, nobody would say, okay, you cannot use those things because they are part and practice of the learning. Same thing would go in the healthcare practice side, in my humble opinion. So how much we have been using that before, and how much in that local setting, in that hospital, in their healthcare facility, how much they have used that, how much have they diffused into their practice. So if they are smart, the healthcare facility would have that already integrated if they want to use that AI component and put that in the informed consent part. Otherwise, there would be a few years, I would say 20, 30 years, when we are going to face the litigations and issues that hospitals will face or doctors will face from lawsuits. So I don't know if that answered the question, but that's how I see that this is going to be part of our everyday life. And yes, radiology has been using that for a long time. Just because even if you look at this PowerPoint, this program is using AI when they give us all those pictures. So we just thought, okay, yeah, it's part of the whole practice. So it's going to be just like that. Maybe not that simple in healthcare.
I'm working with some folks who are dissemination and implementation scientists. And my take home is those folks need to be involved in the conversation. I mean, that's a whole separate academic domain, and how a technology, particularly a technology, gets adopted and penetrates and culture and regulate. I mean, all the stuff we're talking about. And they have these different metrics and models and themes and frameworks and all this other stuff, which I don't think we're taking advantage of. So I think they're going to have to help us inform essentially, how do you get these things to patients? and overcome the barriers.
Yeah, my reaction to that is, I think informed consent rules and laws are definitely outdated. I mean, if you look at just information sharing, right? Google, Meta, Microsoft, when you download an app or when an institution uses, website tracking, there's so much fine print. And when I download an app, I don't read it, right? I just accept the terms and I download it. And translate that to health information in an app where in the fine print, it might say, can I make this request for information for you on your behalf? And I think there's a lot to play there and focus on, what that ethical use of that information is. And then with AI, Arlen, like, I think it's, do we have to disclose a yes or no? And then like, how much do we have to disclose? Like what AI system was used, like how validated is it? Who takes care of the model and its accuracy? Do I just assume the FDA will do that, or that the company will do that, or the health system that uses it does it? Like, how deep do we go with that disclosure?
Well, I think an opportunity is personalized informed consent, AI-driven informed consent. So what does that mean? And in your example of a prostate, that further complicates the issue because now we're talking about preference-sensitive conditions and shared decision-making. Where, for those of you that are not aware, preference-sensitive conditions means, as in early-stage prostate, early-stage thyroid, early-stage whatever, there's 7 different ways to treat it, and they also have the same outcome. And you may have a bias against one of the other treatments. The typical example is radiation therapy, chemotherapy, or alternative immunotherapies, and surgery. And you may say to yourself, well, wait a minute, my Uncle Jack had radiation that totally screwed him up. I'm not letting you do that to me. I don't care if it's a cyber knife or whatever. So the issue has to do with all of these personal factors. And I think, and to Harvey's point, if you can use artificial intelligence, not just to create a discharge instruction sheet, but to create a program that actually walks people through a personalized informed consent so that it's understood consent, not informed consent. And how do you know they understand it? The same way we test students. Did you understand what I just told you? We have tests, we have quizzes, we have benchmarks, we have things. So part of this is adult learning, part of it is instructional design, part of it is AI, part of it is user interface. I just think there's a big opportunity to make it better. And actually, there's been a fair amount of research that looks into what makes informed consent understood consent. And it turns out the more you tell people and teach them it's intuitive, the more they understand what they sign. So I think that there's an opportunity to use this to make AI informed. Again, use AI to make AI informed consent better.
Yeah, I think that that's a great comment and probably a good place to end with that kind of patient-centric approach.
We're going to have to quit in a minute.
Maria, I wanted to tell you that I do have the disclaimer that some images were AI generated. So I did inform you. But there are a few more case studies in the deck. But really, I think we covered the topics that I wanted to cover. Yeah. And thanks for the conversation and the points.
Yeah, you did a great job. Thanks very much. Just to update that next time, Ty Hagler, who's the guy, Ty, he's an expert in design thinking. So he's going to be giving a presentation on design thinking and artificial intelligence. So thank you all for participating. Great conversation, good insights. And thanks very much. I'll stop the recording.